a lot of the early evidence that's coming in is showing that there's a huge backlog of chronic disease patients that haven't had access to appropriate diagnosis, to care, to treatment in the past year. Prior to COVID in 2019, a survey of 10,000 patients with neurological conditions found that 28% of them had been waiting more than a year to see a specialist. So more than a year. As you might imagine, COVID didn't really help that situation. And even though there's been a somewhat miraculous move to telehealth, and this has kept a lot of appointments in the books, a recent analysis of NHS data shows that there's a third less neurology patients in the system in January of this year than there were last year. And so this is somewhat concerning because this means that people are not getting the care that they need.
I think one of the effects that we're going to see coming out of the crisis is that people have gotten out of the habit of, because they haven't been able to having regular health checkups, taking care of conditions which are not COVID. They've maybe been tracking more whether they have COVID, perhaps if we're lucky, their exercise and things that are doing it at home. But this link again to the health system for regular health issues, for dental appointments, which haven't been accessible to many people. And then plus, which is also a major goal for us in the EU, and I think for the science and innovation community globally, getting people to share their data and also to participate in clinical trials where appropriate. I think this is also, at least in a lot of parts of the world, taken a big hit.
If you look at the differences between the medical and social model of disability, for example, within the social model, rather than assuming that there is a problem with a patient or a person who fundamentally needs to be fixed, the social model looks at the world around and determines what is it within the environment that is a disabling factor. So for me, you know, as a person with a physical disability, looking around my world and understanding that there's nothing wrong with me being born with a neuromuscular condition, but that there are many things in the world that are disabling me from reaching my fullest potential. And often, you know, specifically for me, that can be barriers in the built environment or many other things. And so I think, you know, when we expand patient or client health to being person-first health, we can also expand to understand what community health is about.
When we innovate based on the community needs, when we define those needs from the outset, we can create these solutions that really are embraced by those affected. And I think in the past, we've seen too much that innovation has raced ahead, and it's only when the solution is ready to be launched or to be put on the market that those people, or the users, are then consulted. And I think at that point, it's often, you know, we get requests for endorsing or rubber stamping, and that's not good enough. So for me, I think what we need to see is really a culture shift and a major change in attitude when it comes to patient and public involvement in health innovation. Because I think what we've seen during the pandemic is that we can have sophisticated processes developed and in place, but very often when the going gets tough, and as Chaz said earlier, you know, in times of crisis, something's got to give. And I think what we've seen during the pandemic is that this systematic patient involvement has fallen by the wayside at a time, bizarrely, when actually that patient involvement has been needed more than ever.
The phrase "nothing about us without us" is one of the most powerful things that you can live by, including people with disabilities at every stage of a design, at every stage of a solution, is one of the most important ways to make sure that that solution is actually going to be representative and authentic to the needs of people who actually need the solution to begin with.
I think the important thing is that all of us in this ecosystem have to recognize what are our strengths and what are our weaknesses. I think we have to be humble enough to admit what our weaknesses are. And then we need to work with partners who have strengths in those areas.
can take, for example, Huntington's disease, testing is going to be a big issue. But I would actually turn this around and say it's not just a question of having, you know, a really accurate test. It's more of a question of how do you make sure people have access to that testing? How do you speed it up? How do we make sure healthcare systems have the resources to administer it? How do we, to answer the challenge that Donna has said, how do we involve patients in this in the beginning and ask them, do you want to be tested? How do you want to be tested? And how is this integrated into this sort of broader systems of care?
Last year was an extraordinary year. It changed the lives of every single individual on this planet. But I think there were some important lessons, and we shouldn't forget them. Now, I think everybody recognizes that science and technology is important. Universities are important. Industry is important. Regulators and doing stuff at speed is important. Making use of, in the UK, national health system is incredibly important. But manufacturing, diagnostics is important. But the other thing is we need great leaders, great innovators, and great entrepreneurs. It's people who make magic happen. And we need great collaborations and great partnerships if we're going to accelerate solutions to some of the problems that this planet's facing.